Thank you very much, Claudette. It's a great pleasure to be here at such a prestigious university and indeed institute. As the last speaker, one of the issues is always keeping your audience awake, and I've been told I'm not allowed to walk about, which is what I normally do. So if I catch anyone nodding off, I'll just say, stop it. So many thanks. I think what we're talking about is this. Can I just check who here are clinicians, like medical doctors? About half. Complementary therapists, or people who do both. People, researchers, members of the public. Okay. So, what I'm going to talk about is this whole stuff and the clinical narrative which we so commonly cling to as clinicians when we're trying to get through our busy clinic. But of course, the issues beneath that, the human narrative, is part of the patient's life and often part of why they're seeking our help. I want to give you a bit of context and background to what I do and why I'm here, because I don't do anything very fancy or very clever. I do stuff that is pretty obvious, and it's amazing I've got as far as I have. In Scotland, we have quite a problem of inequalities in health. This shows in the pale blue, the pale green, the million most wealthy, the million healthiest people in the UK. And where do they live? Well, all in the south of England. And the red shows the million least healthy people in the UK. And this is Glasgow. And I work in Glasgow at the university and also in practice. Why does this matter? Well, we've got a huge problem of ill health, and it's not equally distributed. So within Scotland as a whole, if you divide Scotland up into deciles of deprivation in terms of where people live, you see that people in the more affluent areas have health which is 2 or 3 times better than in the poor areas, whether you look at premature mortality, limiting long-term illness, or not good general health. Why does it matter? Well, we know that countries that have got bigger inequalities in income and in health and so on have got more social problems. It becomes a less pleasant place to live when you have wide inequalities. The biggest inequalities being in the USA, but the UK is not far behind that. And Scotland is no better than England in this, if anything worse. Scotland has the widest health inequalities in Western Europe. Now, where are we? Here we are, Switzerland. So you're doing pretty well. You're down in the middle there with Germany and Canada and other places. Back to Glasgow. The underground in Glasgow is quite small. It's only a few miles. And if you go from this part of Glasgow, which is in the affluent part of town, where my office is based, not my general practice, but my university office, male life expectancy is 76 years. If you take a 10-minute, 50-minute tube ride, underground ride, to this side of town, Bridgeton, where I used to work as a GP, male life expectancy is 62 years, lower than the life expectancy in India. So we've got a particular problem in Glasgow, and as a clinician, I don't think we can ignore that. My job really is not to study empathy. I just do that on the quiet. My job is the national lead in Scotland for research into multimorbidity, patients with multiple complex problems. And we mapped this out in Scotland using a database of 1.8 million people. That's a third of the Scottish population, which we published in The Lancet in 2012. Unlike Professor Benedetti, this is my only publication in The Lancet, and probably my only one ever. So we're quite proud of it. It's simple epidemiology. We mapped out the percentage of people who have got multimorbidity, 2 or more chronic conditions, across the population, and then split it up by deprivation decile. The richest people in green, the poorest in red. And you can see that in the deprived areas, people develop multiple complex conditions 10 or 15 years younger than in the affluent areas. And because of the size of the sample, 1.8 million, it's a perfect gradient across the deprivation deciles. So for every 10% increase in moving towards deprivation or poverty, so things move to the left. And it gets even more obviously messy when you look at the relationship between physical health problems and mental health problems. So as people develop more physical conditions, then the chance of a mental health problem goes up almost in a linear fashion. But again, this is much higher in the deprived than in the affluent. And again, a perfect social gradient. So when I was working in the East End of Glasgow, I would often see patients with 5 or more chronic conditions, and those 50% of those had a diagnosed mental health problem. So this is bread and butter to general practitioners and family doctors, but this is not well known by policymakers. And I think one of the reasons the Lancet published it is the editor, Richard Horton, isn't a GP. So the work I try to do is messy. It's not easy. It's not particularly academic, I don't think. You probably know this quotation from the philosopher Donald Schoen about in professional practice there's a high, hard ground overlooking a swamp. And as sometimes a hospital specialist, no offense to any of you here, but sometimes a hospital specialist, sometimes academics, occupy this high ground because you can look at solutions through a kind of lens detached from real life. But in the swampy lowlands, that area I've just showed you, things are messy, confusing, not a quick fix. But that's where the problems are of greatest human concern. If we care as clinicians about people, we should be concerned about very wide inequality gaps. These are where the problems lie, not only there, but in the greatest numbers. And I made a kind of choice. I used to be a metabolic biochemist in Cambridge and then Oxford, and I gave it up to do medicine. And I really took a choice to go into this swamp where I knew I couldn't be rigorous in the ways I knew best how to be as a metabolic biochemist. I have to say I'm a huge fan of Professor Benedetti's work, and I think it's got huge relevance to everything we do as clinicians. So it's not an either or. I'm just telling you the context of where I live and what I do. So if you're working in a deprived area, you have patients with multimorbidity, a big tidal wave of problems that hits a clinician who's hardly got his feet on the bottom of the pool. Why? Because despite the gradient in inequalities, there's the same number of doctors in the shallow end than in the deep end. Within the National Health Service, need in terms of medical workforce is not proportioned. The numbers of doctors are not proportioned according to the needs of the population. So there's an inverse care law, and both patients and doctors to some extent struggle to keep their head above water. If you see a doctor, a GP in this part of Scotland, you get shorter consultations, on average 7 minutes long. You've got more problems. Something doesn't fit. I'm going to take you on a bit of another journey now, away from Glasgow, over the mountains to the Himalayas of Dharamsala in North India, where I was privileged to spend a year as a volunteer doctor in my junior days as a youngish doctor in Dharamsala, the home of the Dalai Lama and Tibetans who live in exile in North India. And when I was there, this is a patient, a lovely man I used to meet. I used to do acupuncture on his knees because nothing else worked. Paracetamol didn't work. Acupuncture seemed to. How much of that was placebo or not, I don't know. And this here is not Tibetan, okay? It's Scottish. Owed some power, the gift to Geas, to see yourselves as others see us, which roughly translated means it would be a gift to see yourself as others see you. So I asked people at this Tibetan hospital who had been to the West and who had worked in the West and in this small hospital, what could we learn as Western doctors around what happened in Dharamsala, where the very ethos of the society is around compassion. The Dalai Lama frequently says, "My religion is kindness." And they all said the same thing. It's the human stuff. There was no high-tech medical things. But the human aspects of care, the compassion of the Tibetan nurses was extraordinary. And I came back thinking, yeah, this is actually what it's about. Not the only thing, but it's important. And at that point, there was very little published on on compassion. There's now more research starting now. This is 20 years ago. But there's a bit of a literature on empathy in the Western scientific literature, particularly empathy in psychology, psychological medicine, and to some extent in nursing. So I had a starting place, and I started as a higher professional fellow within Glasgow University, where I luckily had a boss who said, "Do what you want. I'll give you a long leash." He didn't quite know what he was saying, but so I thought, I want to study empathy. So why, if we look at it in purely conventional terms, this is a very well-known framework for quality. What do we need to do in healthcare? Patients need access, and then they need treatments that are effective. And effectiveness involves technical effectiveness, or the specific effect of the medication, or the technical expertise of the surgeon, but also interpersonal effectiveness. And my view was that we have got so hung up on this side, we've neglected this side. I don't know if that's still true, but that was certainly my feeling 20 years ago. And in terms of healthcare, if you ask patients, survey after survey over the last 20 years, tell you patients value top of all an empathic human approach, good communication, warmth, top priorities in their healthcare. This is true around the world, even in low and middle income countries, with the exception of some parts of sub-Saharan Africa, where access is a huge problem because you have to travel 2 days to get to a clinic. Healthcare professionals, complementary therapists, orthodox professionals of all disciplines speak a rhetoric around this. If you look at the Royal College of General Practitioners website, or the Royal College of Physicians in the UK, they all talk about compassion, empathy, and so on. So it's not alien in the way in which we talk about good medicine. And it's known to improve some outcomes. And at this point, 20 years ago, the evidence wasn't so strong. And my kind of task was to do what I could to try and look at that, because many people said to me, many fellow clinicians said to me, okay, so it's fine all this being nice to patient stuff, but what difference does it make to outcomes? Now, 20 years on, at least in the UK, the mood has changed, I would say, and patients would see it as their right to have an empathic doctor. It's something they expect. It's something policymakers and politicians expect. So the mood has changed. I'm not sure medicine's kept up with that, but we do not live in a vacuum, and we're not completely disconnected from the wider changes in society. What do we mean by empathy? If you're going to try to measure something, you've got to define it. And I was taken by Morse's systematic review, which talked about components of empathy. It's not just one thing. There's a series of different aspects. There's a moral aspect, which is about the kind of sense of altruism that drives us to engage in good work as caring clinicians. There's a cognitive aspect to empathy, where the helper, the doctor, or the nurse, or whoever, sort of intellectually understands the patient's problems and the feelings. And it's quite objective. And I worked with a psychiatrist who was a brilliant psychiatrist, but he was absolutely cognitive. He was a big expert in cognitive behavioral therapy, so it wasn't... He wasn't a warm person, but he was he really understood his patients from a cognitive stance. And that worked really well for many, many patients. So it's not to say that's the wrong approach. It may be the best way to do professional empathy. Then there's the emotive empathy, what many people think of as empathy. the ability to subjectively experience sharing those psychological state or intrinsic feelings, walking in the other person's shoe. And this is where it gets, for many people, controversial, because some people just don't believe in this. Some think you can't do that as a doctor. Others think this is what it's all about. And I think it's a mixture. And I think some individuals have this much more than others. The nice, warm person who will, we used to have a nurse in our practice, and she used to hug the drug addicts who were often homeless and certainly from poor backgrounds. And I think that was a very therapeutic thing to do. But she didn't ask permission, she just did it. Not everybody could or would do that, and I'm not recommending it, but some people just can't help being like that. And then there's a behavioural aspect where you communicate in whatever way back to the patient that you've got some understanding of how they're feeling. It's very important to check, am I getting this right? Am I hearing this right? I think this is what you're telling me. Okay. Defining empathy in the clinical context. So I wanted to measure empathy in fast, high-volume medicine in general practice, where patients are getting 7 or 8 minutes. And I wanted a definition that matched that. And I liked this definition by Reynolds, and others have published very similar definitions, that essentially in clinical empathy, it's an ability to try and understand the patient's situation, perspectives, feelings, attach meanings, to communicate that understanding back, check its accuracy, but then to act on that with the patient in a helpful or therapeutic way. And this may go beyond a strict definition of empathy in a dictionary, but this is exactly what we do as clinicians. We don't say, yes, now I understand, next please. We don't say, stop it. We work with the patient to do the best we can with them. And the working alliance, therapeutic alliance, of course, is crucial to that. So I was interested in measurement. And why measure empathy? Well, if you're a surgeon, you can prove that you're good because you've got mortality and complication data and logbooks. If you think you're a patient-centered empathic doctor, well, I did a course, nobody's complained. I got a Christmas card from the patients last year, that shows it. So if we don't measure something, it's not valued. We live in a culture that is about numbers. And I looked at the literature, and I couldn't find really any good measures that I could use routinely in busy practice, where patients, even from very deprived areas, could fill in easily without much help. Because most of the measures back then had been developed for psychiatry. Some of them were 100 or more questions long. So I somewhat reluctantly embarked on trying to develop and validate a measure. And so I did this on the care measure, the consultation and relational empathy measure. And we reviewed existing measures. We did a preliminary validation, and much of this was not just the statistics, but actually interviewing patients, doing qualitative research, asking them what makes a good consultation, what makes a good GP, what about the human stuff. And I did it in very deprived parts of Glasgow, and I did it in the richest parts of Glasgow, which are quite rich. And because I wanted to get something that covered both right across the socioeconomic spectrum. And then we piloted this, then we tried it out on a pretty big study, 3,000 consultations in general practice, family medicine, about half of them in very poor areas and about half in more affluent. And then we've done the same in secondary care, and now over the last several years, different languages and settings, particularly Hong Kong and Japan, and a few other places. So it's a simple measure. It's got 10 items. Patients just have to fill this in after they see the practitioner, and it asks the patient, how was the provider or the doctor, the nurse, the acupuncturist, the homeopath at? And your response is the patient can say poor up to excellent, or that might not apply, because this doesn't apply to every consultation. And the items are around making you feel at ease. Now, we tried to anchor this by putting in kind of riders around what that sort of meant, being friendly and warm towards you, treating you with respect, not cold or abrupt. And this came very much from what patients said. So I tried to use the patient's own words in making up these explanatory statements. I'm not going to go through them slavishly. The website is, we have a website you can look up. But the items matched the definition by Reynolds as much as we could. That was our starting point, making you feel at ease. Oh, sorry. Letting you tell your story, really listening, active listening, being interested in you as a whole person, not just a number, fully understanding your concerns, accurately understanding concerns, not overlooking or dismissing anything, showing care and compassion, genuinely concerned, connecting with you on a human level. This was trying to tap into that emotive aspect of empathy, not being indifferent or detached, being positive, explaining things clearly. This gets to the last part of the action, the therapeutic action, doing something beneficial or helpful, explaining things clearly, answering questions, helping you to take control, exploring what you can do to improve your health, encouraging rather than lecturing. So trying to get into that working relationship and therapeutic alliance. And then making a plan of action, which includes shared decision making. This is almost a religion now in the UK amongst policymakers. You get shot if you don't do shared decision making. The fact that many patients don't want it doesn't really matter. So we said involving you in decisions as much as you want to be involved. Because in deprived areas, 70% of patients say the doctor should make all or most of the decisions. And when you ask them why, they say, you're the bloody doctor. You're getting paid a load of money. I don't know what to do. You tell me. And in affluent areas, complete opposite. 70% of patients want to make all of the decisions or most of the decisions themselves because they're educated, informed, and empowered. Is it relevant? In this study, when we looked at 3,000 consultations, we asked the patients to rate not just the scores, but to say if they thought the items were important. And 70 to 80% said very important to that consultation. And the doctors who took part also thought the items were important. We've gone through the whole host of usual ways of validating and doing reliability testing, and it is probably one of the best validated measures of patient-reported experience measures. The key thing I wanted to know is, apart from using this in research, could we differentiate between practitioners? Will it tell the difference between an empathic doctor and a non-empathic doctor? And the problem with that is patients tend to give you high scores. So could a tool that has a ceiling effect actually differentiate between practitioners? And how many patients do you need per practitioner to get an accurate score of that practitioner's average empathy? Because if it's 1,000 patients, it's not a useful measure. You can't use it for that purpose in practice. And using a technique based on generalizability theory, on these 3,000 consultations, and 26 GPs took part in this initial study, we found that reliability increased with sample size, and that once you got to 50 patients per doctor, you were in a highly reliable situation. So if you get 50 patients per doctor, if you were to repeat that on the same doctor under same circumstances, it would give you the same mean score or very close to it. And then in terms of the scores for the doctors, we then, for these 26, we plotted these out. So we had doctors whose mean scores lay in the average and within the confidence intervals of average, those above average and those below average. And we now have this data on about, 10,000 healthcare practitioners, and we have a website which is free of charge, which they can put in their scores and they'll get feedback telling them where they sit in relation to the other 4,000, whether it's above average, average, or below. So I invented the care measure, worked on the care measure as a research tool I wanted to sort of see if it had any effects on outcomes. But I got kind of distracted because I got involved with policymakers, which is always a bit of a mistake, potentially. Now I'm very involved with them as the director of the Scottish School. Nothing against them, they're wonderful people, but it's a different world. And they, pretty quickly I got approached saying, can we use the care measure in GP appraisal in the UK? Because appraisal was coming in around 2012. Every doctor, every GP, and now every doctor has to have an annual appraisal and 5-yearly revalidation. I'm not sure the situation here. So it came in for that. It then got asked if it could be used as part of the membership exam for the Royal College of General Practitioners, which is a compulsory exam. You must do this to be a GP in the UK, and it's part of workplace-based assessment. And the care measures used for that. The Scottish Government, in its wisdom, then recommended its use not just for GPs, but for every healthcare professional in Scotland in 2010, and that recommendation still stands because this quality strategy has not been updated. And then it's also been used for revalidation across the UK by the General Medical Council for quite a number of years. So I think Scotland might be one of the few countries in the world, if not the only country, that uses a measure of empathy to judge the quality of care of its doctors. It's by no means the only measure, okay? So don't think this is what it's all about. It's only one of many other measures. And the technical skills of doctors, the safety aspects, hugely important. So care measures then kind of taken off over the world. Lots of countries use it. I think that's because it's free of charge. I didn't think I should try and make money out of empathy. It's in a number of languages and so on and so forth. So what makes a difference to the scores? Patient factors. If you look at the patient factors, then gender, male or females filling in doesn't matter. Socioeconomic status of the patient doesn't affect the scores, which is good because that's how I developed it. The reason for consulting isn't an influence. Whether patients have chronic illnesses or not, or mental health status. We found no effects of these on the actual scores that patients gave to individual clinicians. A small effect of age. Older patients tend to rate the doctors more highly. That may be because they're more generous, or it may be that with older patients we're more empathic. I don't know. In terms of the consultation factors, you know, things you can change potentially, then higher empathy scores are associated with longer consultations and with relational continuity. So knowing the doctor well, if you know the doctor well, you tend to give them a higher score. But it's a very weak correlation. And doctor factors, this is pretty important. Doctors with low care scores, we did a survey of the doctors and matched what they said with what the patients said. And the ones with the low scores felt undervalued by patients. They felt undervalued by colleagues. They didn't think that empathy was very important, and they rated their own empathy lower than the doctors with high care scores. And they didn't think longer consultations were necessary. So these are the biomedical GPs, of whom there are quite a lot, who don't buy into this whole biopsychosocial model. Often they've come from specialties like surgery and so on and moved into general practice, and I think it's an uncomfortable place for them. And what happens is they, if they're not careful, they begin to burn out. In terms of further work, there's a really good systematic review and meta-analysis just been published by Jeremy Howick in Oxford, where he looked at all the papers that had been published using the care measure, not just by myself, but worldwide, and then he got 51 publications from which he did a meta-analysis. And I won't go through all of that. Most of it confirmed what we knew, but there's some new findings. Empathy generally is higher in female clinicians than in male across the piece, and we know that from other work. But I'll let you, you can have the slides, of course. Effects and outcomes. So This is what I started. 20 years ago, I wanted to know about outcomes because I wanted to say to the hardliners, does it affect patients' outcomes? I wanted to be able to say, yes, it does, or no, it doesn't. So how are we doing? Anybody falling asleep? Are you doing very well? In Glasgow, half the audience would be snoring by now, or drinking. So if you look at the relationship between care scores and patient satisfaction, would you recommend this doctor to family and friends? Then a very clear relationship, and it's the same whether you're a patient who's deprived and poor, or affluent and rich. And this isn't new. Many other studies have shown this for different empathy measures and so on. So if the patients perceive the doctor to be empathic, they feel satisfied by that consultation. Now you might think that's a soft outcome. What's the biggest cause of litigation within the health service? Poor communications, patients not being satisfied with the consultation. It's not when things go wrong, disasters are wrong, that's a minority. 80% or so of claims in the UK are basically because the patient felt the doctor didn't explain things, didn't listen, and so on and so forth. A number of years I've been interested in this measure called enablement. John Howey in Edinburgh developed this a long time ago. And it's an outcome of the consultation. It says to patients, at the end of the consultation, it's another short questionnaire, as a result of the visit to your doctor today, do you feel more able to cope with life, understand your illness, cope with your illness, keep yourself healthy? Nowadays, we'd call this self-management support. Very, very topical. And what we found is that patient enablement never occurs with low empathy. So in this study of 3,000 consultations, we didn't get one consultation where a patient felt enabled but saw the doctor as low in empathy. You can get high empathy but not enablement, because enablement's a complex structure, a complex thing. It's affected by patients' age, the pain they're in, the different number of conditions, and so on and so forth. So it's not a linear relationship, but you don't get enablement without empathy. In terms of outcomes, I looked at this in a number of studies, small studies generally, of a few hundred, less than that often, in acupuncture patients, in the homeopathic hospital. This again, the homeopathic hospital outcomes over a year. This one, prospective study of acupuncture, where we looked at care measure scores at the first consultation, predicting outcomes 6 months or so later. So it's not cross-sectional, it's not just association, it's a predictive effect. And also Melanie Newman, who some of you may know, she working in, when she was in Munich, I think, did her PhD on empathy using the care measure in German, and looked at this in oncology patients, and then we published work together looking at patients in a single practice in a very deprived part of Scotland. All of these showed the same thing, positive effects of empathy on patient outcomes, however measured. But the biggest study I've done is this one, where I had a mad idea. You do these things when you're younger. I thought, I know, we'll do a really big study and we'll collect patients' measures before the consultation, expectations, straight after the consultation, a month later, and we'll video the consultations as well. Sounded easy. I got ethics for it. So we did it. 659 patients attending 47 general practitioners, about half of them in high deprivation areas of Glasgow, and about half in low deprivation areas or rich areas. This was a huge amount of work, which I would not recommend to anybody unless you've got a large team and a very big grant. So then we analysed those videos for a variety of things, including verbal and non-verbal physician behaviours, verbal, non-verbal communication, using validated measures. And at 1 month, we looked at changes in symptom severity using the MyMops, which is a very patient-centred outcome measure. The patient puts in the symptoms they discussed and how much the symptoms are affecting their life at baseline when they first see the doctor, and then a month later, the same questions. So you measure the change in symptoms and also in well-being. And we then did a lot of multi-level, multi-regression modelling to find out what it all meant. Patients in deprived areas, not surprisingly, had more less desire for shared decision making. As I've said, they had more problems to discuss than patients in the affluent areas within the same consultation time. So the consultations in this study were not shorter, but they were no longer. So you got a patient who wants to discuss 3 or 4 problems in a deprived area, they still get the standard 10-minute consultation, of which 8 minutes is face-to-face, compared with the affluent areas. It doesn't change because that's our system. So the patients in the deprived areas perceived their general practitioners to be less empathic, using the care measure, and the physicians displayed verbal and non-verbal behaviours that were less patient-centred. So it wasn't just that the patients didn't like the doctors and thought, give them a bad score. The doctors were less patient-centred, and the outcomes at 1 month were much worse in the deprived than in the affluent groups. Importantly, when we looked at all of the things that predicted better outcomes at 1 month, I mean, most of the factors were nothing to do with the doctor or the consultation. Most of the factors are to do with the level of complex multimorbidity that the patient has. But when you account for those things, the only thing that predicted outcome was a perceived physician empathy, the care measure scores. I could rest at this point. I thought, well, we've set out to show something, and I could tell the critics about that. So, and this is quite important, because if empathy is important, it's got to do with the context of these consultations. And these are not bad doctors, but they're suffering from being in the deep end, the inverse care law. So many problems, so little time. So there's been various reviews of empathy in general practice, and there's not a lot of trials, but this one by Franz Dirksen concluded that empathy is probably important in general practice, or he said unquestionable importance. Maybe a bit too strong. How does it work? I'm not going to go through this. Melanie Newman published, and I published from her thesis, a model, a theoretical model for how empathy may work. This shows that one part of that may be through, if you engage more with the patient, you better understand their needs, and you can tailor self-management, for example, to the individual patient. We also know there's direct effects of empathy, and direct effects on, for example, the immune system. But how long those last, we don't know. Okay, I'm going to finish quite soon so we can get some discussion. Having done all this work, and the Scottish Government putting the care measure into the NHS and all health professionals to use it, and us setting up a website to let them do that, I made the mistake of saying to one of the senior policy people, not the minister herself, but I said, what if somebody's got a low score? What if a GP's got a low score? What do we do about it? And I said, what are you going to do about it? And they said, well, what are you going to do about it, Stewart? And so I said, well, don't know, you have to give me some money. So they gave me not very much money to try and develop a tool to try and help practitioners who maybe are down in the lower end of the scale. So we developed the care approach, and it's derived from the care measure. So it's which was derived from the definition of empathy I told you about. And it's called care because it's connecting, assessing, responding, and empowering. And the government loved this because it rolls off the tongue, care, connecting, assessing. What was the next one? Yeah. So we developed this care approach as an online learning tool. It's web-based. It's 6 modules, and now it's a bit more than that. And we start by going through what you as a person brings to the encounter, as the practitioner, beliefs and values. And then we go through each of the letters, C-A-R-E, in different modules, and then we put them all together at the end, because dividing this stuff up into linear things isn't really how consultations work. You're connecting all the time, including at the end. So we wanted to describe this. It has to, this is something, the feedback's been good, but I was worried, it's not very high level. This is for practice nurses and phlebotomists and anybody and everyone within the NHS, many of whom never ever have had any communication skills training. Unlike doctors, medical school, we get quite a lot. So it's something that's generic, and it's now been out for a few years as a book. I have to put my hand up and say conflict of interest. For each book that's sold, I get a bit less than 1 Swiss franc. So if you all buy the book, that could pay for my taxi back to the airport. Thank you very much. In Scotland, it's available free of charge on this web system. It's been piloted independently while I was involved in writing the paper, but not in the collection of the data, and in 5 sites in Scotland. And staff loved it. They really liked the idea you could work at this. We did it as a group. There was a facilitator from within the practice, and they did it over a number of weeks. The feedback's been very positive. From this, we don't know if this actually changes the care measure scores, but it certainly changed the healthcare professionals' self-perceived empathy, and we need future work to show its effects. I have to say, I'm not the only person in the world doing this research, so there's been lots of very good interventions about improving empathy. Helen Rice, for example, who's in America, I think Johns Hopkins, has been doing fantastically interesting intervention development and trials showing that you can improve clinicians' perceived the empathy and the perceptions of that by the patients. So there's a growing evidence base around this. What I do want to do, just to finish, is tell you quickly about this Care Plus study. So, for my sins, I'm in the deep end, okay? There's no quick fix. Life's tough. And I wanted to show, well, okay, empathy is important. How do you operationalize that when patients have got so many problems, consultations are short, the doctors aren't very patient-centered because they're just trying to survive? What can you do about it? So as a lead for multimorbidity, I thought, let's show if we can do something there in the deep end, because if it work there, it's likely to work in the more leafy parts of Scotland. So we did this program funded by the Chief Scientist's Office in Scotland to do a proper complex intervention development study where we worked very closely with patients with multimorbidity, doctors and nurses working in deprived areas, and using theory and literature to develop a complex intervention. So a complex intervention is where you've got more than one thing in it, more than one active ingredient. And we did tried to do a kind of experimental whole system approach. At system level, we said to the GPs, everybody said to us, we need longer consultations. 8 minutes isn't enough. Patients said it, doctors said it, nurses said it. So we said, right, here's money, employ locums to do all your routine stuff, and give these patients selected for the trial much longer. And we piloted it because the GP said, yeah, 20 minutes, fantastic. We piloted it, the GPs came back and said, 40 minutes minimum for the first consultation. So we've paid them. Getting GPs to do stuff is like herding cats. But a friend of mine, Tom O'Dowd, a professor of general practice in Dublin, said, if you want to herd cats, you just move the food. So we paid. We said, right, we'll give you the money, you do it. So the doctors gave these long consultations to very multimorbid patients in the most deprived practices. We only went to the deep end. They needed support as well. We had support meetings on structure. We taught them the care approach. And we also did stress management and mindfulness, because they're stressed. These are not bad doctors. They're really toiling, particularly the younger ones. And then for the patients, we had some additional self-help material with some CBT and mindfulness. So it's a complex intervention. We can't unpick one thing that works here. But in these circumstances, in the deep end, in the swamp, you just want to show that something works because there's so much doubt. So we found there's a cluster randomized controlled trial, 8 practices randomized, 4 got the intervention, 4 didn't, and 156 patients in total, 152, 76 in, no, whatever, 76 in each arm, 152. So it's not a big trial, it's not definitive, but it's not so small. And we found that in the practices and patients randomized to care plus, as we called it, the care measure scores went up compared with the control practices, and patients felt more enabled compared with the control practices. We measured outcomes at the end of 12 months, and we were interested in quality of life and well-being. And this wasn't powered to find any effect. It was a feasibility RCT, a phase 2 feasibility RCT. But we did actually find effects on health-related quality of life with the Euroqual and on some aspects of well-being. So this was very encouraging. What was most encouraging for me, I think, is it was very, very cost-effective. So in the UK, the government will support interventions that cost £20,000 or less per QALY, and this came out at £13,000 per quality. We're not paying for new therapists to deliver services. We're allowing the GPs to do what they say they want to do by giving them some extra support for targeted longer consultations. So, and the other thing about this is, when I did this, I thought, fine, great, but it'll never happen. We'll never get longer consultations. So now, a few years on, the Scottish Government is now, we're going to have a Scottish GP contract. The main part of that, the quality outcome framework, the single disease focus, is out. There's no pay for performance. And the main feature of this contract will be freeing up GP time by having other healthcare professionals see patients for minor illnesses and straightforward things, so GPs can spend longer with complex multimorbid patients. So I'm not saying this study led to that policy decision. It didn't do any harm. But this is something that I could not have imagined 5 years ago. So the world changes quickly. So just to summarize, everybody seems to think empathy is important. Care measure is only one measure, but it's probably the best validated to use in a general setting. It predicts patient enablement and improvements in outcomes, and at least in a complex intervention, empathy can be improved by training to some extent, and in a complex intervention, it may improve outcomes in a cost-effective way. Thank you. Thank you, Sharon. You can break up now.